Hello, my name is Joyce, and I'm a registered nurse with experience in critical care. Today, I'll be presenting the con side of the debate motion that family members should be considered essential partners in acute care. While family involvement can be valuable, I'll be arguing that making them essential partners in acute care is problematic. My position is based on three key arguments. Number one, family involvement does not consistently improve outcomes. Number two, emotional support from families can escalate into stress and conflict. Number three, labeling families as essential partners increases staff burden, stretches limited resources, and introduces safety risks. Throughout my presentation, I'll be drawing on evidence from literature review and clinical experience to support this position. In my speech, I will first define the key terms of the debate. Second, I will present three arguments showing why family members should not be seen as essential partners in acute care. Finally, I will provide a conclusion. Let's begin by defining the key terms. Acute care is the healthcare system components or delivery platforms used to treat sudden, urgent, or emergent episodes of illness or injury that can lead to death or disability without rapid intervention. For inpatients, this refers to necessary short-term treatment for severe illness or disease episodes, typically provided in hospital settings. Family members is a broad term including immediate and extended relative, as well as individuals considered like family, whether or not connected by blood, marriage, law, or formal partnerships. Patient and family centered care is a healthcare approach that promotes respectful partnerships between providers, patients, and families, emphasizing shared decision making and active family involvement. Essential partners are individuals identified by the patient, such as family friends or caregivers, who play a key role in patient safety, decision making, care coordination, and continuity of care. They offer physical, emotional, psychological support, participate in care activities, and are supported by healthcare professionals. Shannon, representing the pro side, needs to demonstrate that family members should be essential partners in most or all acute care situations, not just that their involvement can be helpful at times. My role on the con side is to show that making family members as essential partners is unrealistic, introduces serious risks, and is not consistently supported by evidence. Now, I will move on to the part of the speech delivering my three arguments. Argument number one: family involvement in healthcare is often viewed as beneficial, but the idea that it always improves outcomes isn't fully supported by evidence. This is especially true in acute care settings, where decisions are time sensitive and interventions are highly technical. Halo et al. Point out that there's limited information on how family involvement actually leads to better patient outcomes. Without that clear understanding, it's difficult to claim that family involvement consistently enhances care. Some data from Healthcare Excellence Canada show improvements in areas like hand hygiene, medication self-management, and incident reporting. But when it comes to more clinical or pathophysiological outcomes, such as wound healing or intubation success rates, there seems to be a lack of strong measurable evidence. And with patient and family centered care implemented inconsistently across systems, it is difficult to assess whether these approaches actually improve outcomes. Another important consideration is that not all patients or families are ready or even willing to engage in care activities. According to Healthcare Excellence Canada, poorly planned involvement can lead to tokenism, unmet expectations, or confusion. Simply involving families doesn't guarantee a positive impact, and many patients and providers report lacking the knowledge or experience to engage meaningfully, which is another issue Guaza and Masiska identified in their study. In some cases, family involvement may even impact care negatively. A study by Mayberry and Osborne found that family members of adults with type 2 diabetes often perform actions that undermine the patient's self care, such as planning unhealthy meals, questioning medications, or using negging and criticism as an attempt to support. These obstructive behaviors were associated with reduced motivation, lowered self efficacy, and poor adherence to a treatment. In their findings, family behaviors explained just 22.9% of adherence to exercise, 21.2% to general diet and less than 10% for medication and specific diet. They concluded that families often impede care as much as they support it, and that assuming more involvement is always better can be a mistake, especially when family members lack the tool or knowledge to provide effective support. Ultimately, when it comes to patient outcomes in acute care, good intentions alone are not enough. Effective support must be informed, consistent, and clearly defined. Argument number two. While family involvement can offer emotional support, in acute care settings, it often risks escalating into emotional strain for both families and healthcare providers, leading to tension, conflict, and even safety hazards. Hospitalization is often sudden and overwhelming. Families may find themselves in unfamiliar environments, expected to make urgent decisions, process complex medical information, and support their loved ones emotionally, all the while managing their own distress. Halo et al. Notes that families frequently take on roles such as decision makers, advocates, and caregivers. But without preparation, this can lead to strained interactions with staff. Korea et al. Adds that families may consume nurses' time, add care complexities, or become verbally aggressive, contributing to workplace tension. These emotional pressures can also affect patient care. Families may unintentionally transfer stress to the patient or try to take control of the treatment decisions. Some providers feel this compromises patient autonomy. Nurses describe family presence as, at times, intrusive, and some physicians worry that relatives asserting themselves as experts may silence the patient or challenge the care plan. Healthcare Excellence Canada warns that such dynamics can create power imbalances, role confusion, and fears of negative outcomes. Guaza and Missisca provide a clear picture. Some families staying at the bedside without rest, food, or sleep, emotionally and physically drained. Parents report insomnia, pain, financial strain, all of which carry over to the care environment. Bala et al. Notes that some families seek constant reassurance and empathy, which may not always be met at acute care settings. In March of 2025, a 2-year-old boy with a tracheostomy, Theodore Lim, was taken from the BC Children's Hospital in Vancouver by his father that triggered an Amber Alert. Angry and distrusting the system, the father later said he felt misheard. This case shows how quickly emotions can spiral out of control when families feel excluded, posing risks to everyone involved. In the end, emotional support is important, but in acute care, it must be balanced with boundaries and structure. Unstructured involvement can lead to confusion, conflict, and unintended harm. That's why it's essential to recognize both the potential and limits of family engagement in these high stakes environments. Argument number three. Labeling family members as essential partners in acute care increases staff burden, stretches limited resources, and introduces safety risks, especially when families lack clinical knowledge, role clarity, and preparation. Involving families in care can sound supportive in theory, but in acute care settings, where time, staff, and resources are already limited, doing so without clear structure or training can have serious consequences. While families may offer helpful insights into a patient's preferences or routines, they're often unfamiliar with the technologies, pace, and complexity of acute care. Without defined roles or supporting policies, nurses must manage and guide untrained caregivers, adding to their workload, complicating communication, and increasing the risk of errors. Guaza and Masiska found that many hospitals lack formal policies or guidelines on how families should be involved. Without role clarity, communication becomes inconsistent and collaboration breaks down. Nurses may pull back or even avoid engaging families due to fears around unclear responsibilities and liability. The review also highlights inconsistent patient and family centered care implementation, with barriers like staffing shortages, poor role negotiation, and lack of organizational support. In some cases, families are asked to help with feeding, hygiene, or even wound care and oxygen administration, tasks they are not trained for and often unaware of the rationale behind. This creates serious risks for both patients and family members. Bella et al. Adds that caregivers often face overcrowded space, no privacy, and limited facilities, making even basic tasks stressful. Nurses, meanwhile, are expected to support and involve families while still meeting critical clinical demands. Drakenberg et al. Reports that this emotional labor, ensuring families feel informed and included, has quietly become part of the nurse's job, despite little training or time for it. In my practice, I once had a family member who's an engineer asked if we could connect two dialysis machines together to double the benefits. It was a well meaning question, but also completely unsafe. It took time and explanation from the team to clarify why that wouldn't work. In a busy unit, misunderstandings like this can quickly add up, showing how good intentions alone aren't enough to keep care safe and efficient. Healthcare Excellence Canada echoes this challenge, noting that while engagement is valuable, it takes time, effort, and resources, none of which are in abundance in acute care. Without these supports, true partnership becomes unrealistic and unsafe. When roles are undefined and policies are missing, nurses are left managing both clinical care and coaching unqualified caregivers on the fly. That's not collaboration, it's taking unnecessary risks. And in acute care, that risk can compromise patients. In conclusion, while family involvement can be meaningful, making them essential partners in acute care puts patients and staff at risk. I urge you to join the con side because without clear roles, training, and support, this approach does more harm than good.